Hello everybody, I'd like to welcome our audience wherever you come from. I'd like to thank my three fellow panelists for joining us tonight. Our guest today is Dr. Jack Farr from Indianapolis, Indiana. He's going to explain the procedure that he does frequently for patients who have had a bony injury where the joint surface has been damaged.
This is a technique that I've been doing since 1998. Unfortunately, in the United States, this is the same technique that we're still only able to use. Fortunately, many of my friends in Europe, Australia, and Japan have second and third generations already, but it's all based upon cell therapy. And cell therapy in this technique is using some of the patient's own chondrocytes. The chondrocytes are the little cells that actually keep what we see with our naked eye, the cartilage. The cartilage, I have a little knee model here, I just happen to keep in my pocket all the time. You can see that here's the femur bone, and then on the end, you can almost call these two little knuckles. These are called the condyles. And in the patient we're going to see, the inside condyle, it's called the medial condyle. So if you put your knees together, that's the medial condyle. You can see this is white, and this represents the articular cartilage. The articular cartilage, as you said earlier, is the material that's actually living, that's covering and protecting the bones. If the analogy is a tire on a wheel, if we had cars with little cells in the rubber, we could have tread that would stay there forever. In an uninjured knee that has a good genetic background, the cartilage can last a lifetime. And in fact, I was just talking to a reporter today about, is arthritis inevitable as we age? And the answer is no. Unfortunately, we have so many risk factors: genetics, alignment, sporting injuries, other trauma, obesity, lack of exercise, that many people do as they age have more problems with the cartilage. So the intervention that we're doing right now is typically directed at those less than age 50. There's certainly a huge number of those, and our goal is to take these people with injuries, and instead of them going continually downhill, is to have them sort of level off and maintain their knee function and comfort. Well, this is a healthy teenage girl that had a small region of her knee. Actually, the bone was having a problem. The condition is called osteochondritis dissecans. It's very rare among the normal population, but in my practice, it's not uncommon. As the knee tries to heal the bone, many times there's a problem with the cartilage overlying it. It's much similar to if you have an asphalt road and there's something with the underlying material, say there's rocks under there and they get washed out. Well, initially the asphalt is going to look fine, but over time, if you drive the trucks over it, the asphalt is going to break up and you're going to have a pothole. And so in this case, that's what happened. So she has a pothole in her knee. So at arthroscopy, we do look around about the meniscus. Well, we look at both menisci, we look at the ACL, we look at the entire joint, assess how large the lesion is, and if it's a candidate for this type of treatment, then we will take a small piece of cartilage from the patient's own knee. It's in an area of very low loading, so we're not injuring the knee. And it's about the size of 2 Tic Tacs. And then we send it to a company, and the company has very advanced technicians that will take the piece of cartilage that you see physically, and they will digest it and bring out the cells. So from a piece of about 2 Tic Tacs, you may have maybe 200,000 chondrocytes. And then they will culture those, and they will go from about 200,000 cells to about 12 million cells. And then they will ship those cells in suspension to us at the time of this surgery. The little cursor is showing the lesion, and around the lesion you can see that pristine, shiny white material. That's the articular cartilage. That is what's protecting the bone. It's about 2.5 millimeters thick. In this case, the surrounding tissue is completely normal. So she just has an isolated pothole, which is, as you can see, relatively large. So that's the problem. The next slide is going to show the initial management. So in this area, you can see now it's gotten a little larger, and what we've done is remove any questionable material and clean up the margins so they're nice 90-degree or vertical margins. And you can see at the base, it's sort of pink to red, but there's no active bleeding. So that's because the bone in the past was injured. Now it's healthy, so that's why it's red. And we do not have the tourniquet up now, and you don't see any bleeding. So it's very important to have what we call good hemostasis or control of bleeding. So what we've done in this case, originally described by Lars Peterson from Sweden, he first published his results in 1994. He was using periosteum, which is the thin, it's a fibrous sort of tissue overlying our long bones. And he was using that as a patch to cover the defect. In Europe, they started using a porcine patch. It's collagen 1,3, so it's just a collagen material, no cells in it. And the advantage of that, some of my fellow cartilage surgeons, we got together and we compared our last 100 patients using the periosteal patch to our next 100 patients using this patch, which is the porcine collagen 1,3 patch. And we found a marked diminishment in reoperations because of periosteal hypertrophy. I know I'm throwing out a lot of terms and you can pick them off one at a time, but basically the patch would overgrow. So you would get good cell growth, but the patch would overgrow. The patient would have to have another surgery. They could still have a good result, but no one likes to have more surgeries than absolutely necessary. So in this case, I'm now trimming this patch so that it will match the defect. We're not going to show another slide, but that slide would show that I'm taking some of the cells and injecting them directly onto the patch. The patch has a very smooth side that's going to articulate with the rest of the joint, or that's going to be exposed to the rest of the joint. The side that's going towards bone is rough, and that allows the cells to adhere. A German surgeon showed that the cells rapidly adhere. They adhere very thoroughly within 10 minutes. So from the time we apply the cells, we can then rapidly transfer it. So as you can all tell, this is an open surgery at this point. And this shows, so you can see that the patch looked a little rougher than it does now. It looks very smooth. That's because the rough side is down towards the bone and the smooth side is facing up towards us. You can see that I'm putting suture. This is very fine suture. It's 6-0. A lot of times we're using O and number 1. This is very, very fine. It's when I had to start wearing glasses, and I didn't stop. You can see the needle exiting the articular cartilage. When somebody told me you could sew into articular cartilage, I thought they were crazy, but it does hold quite well. And so the goal is to sew this so that you have a nice, smooth, sort of a manhole cover of this patch into the defect. These are the cells, and the amount of fluid, that's a little angiocath, and I'm going to take the cells out of this vial. The amount of fluid is only 0.4 milliliters, so a very, very small amount to have 12 million cells in. And then the next slide, we'll take those. So we've already applied cells on the rough surface, and now we're applying another vial behind the patch. So you can see my angiocath sort of tinting the patch. You can see that I've applied sutures, and they appear somewhat hazy. The reason why the sutures appear hazy is that I've taken fibrin glue, which is a natural glue formed out of the same type of material in your body that forms clots. So it's fibrin glue, and have further sealed it so the cells won't leak out.
What is the length of time before you get a fairly good infiltration of new chondrocytes into the area and some substantial tissue healing? What's the rehab course?
Rehab is extremely important. With rehab, you can help the cells. As we all know, different tissues like to do what they do best. So hearts like to beat, and the muscles like to contract. And guess what? Chondrocytes, what do? They slide and glide and have repetitive loading. So they like to see early motion. So we actually put them in CPM. I put them in 6 hours after surgery. So they're starting gentle motion. And I go for as much motion as the patient can comfortably tolerate. So we want early motion. With that, we have a lot less adhesions. My reoperation rate is very, very low for adhesions. Then you ask a second question is, how do the cells multiply? Well, we don't do human experiments, but they do animal experiments. And looking at those, we can make some inferences. And if you want to think of these cells, because it's actually a suspension, the cells start off very watery, then they adhere, and then they are still multiplying, they're migrating around, and they're starting to make the matrix. And if you want to think of this, so the stuff that we actually see with our eyes, that's the articular cartilage. But it only represents within that maybe 5% to 10% cells. So those cells actually make the stuff that's outside it. We call that the extracellular matrix, and it has proteoglycans and collagen. We can talk about those things. But over time, those become more mature and more robust. So it's sort of like Jell-O setting up. If you want to think about the first 3 months, it's that warm, kind of soupy Jell-O that's starting to set up. And at 6 months, it's pretty well set up, but it's not fully firm until maybe 9 to 12 months in most types of lesions. Some of them, it takes almost 2 years for them to become fully robust. That would be at the patella, because that's the thickest articular cartilage that we have in our body. So during that time, the first emphasis is, and this is great talking to you as a therapist because I've not talked to you before, and I'll see how much you agree with this, but so I'm trying to load them but not overtax them. I'm allowing people, especially for this lesion, they're minimal weight bearing, but I like to have normal gait minimal weight bearing. So when people talk about toe touch, I think that's very non-physiologic. So I like for them to go a normal gait, and they're putting 20, 30 pounds. They're putting the weight of their limb on it. And that's until, especially in these smaller lesions, a lot of these teenagers, they're off crutches when they come back at 4 weeks. Adults maybe 6 weeks. Keep low impact activities. I really like to emphasize core strengthening because it's great for the knee and yet is not impacting my implant at all. They start biking as soon as they can get on a bike. And so for the first 6 months, that's about where they're staying. From 6 to 9 months, they can gradually increase their activities as long as they have no pain and no effusions. Effusions means swelling. And then when do they get to go back to their desired activities? Typically it's a year. I treat people who play sports, but when I have a discussion with cartilage restoration, my first discussion is you have a knee that's not even giving you good function and comfort. They can't even walk around and they're still having pain. So our goal is to get you back for activities of daily living, comfort and function. If we can get you back to sports, that is icing on top. It certainly does happen. I mean, everybody has examples of it. But that's not the number one goal, it's the number 2 goal.
Could you make an estimate as to a percentage of if you had your ideal candidate, would they be 50% likely to get back to some level of physical activity, not necessarily what they were doing prior to surgery, but some level of a physically active lifestyle?
We use different rating scales, patient-reported outcomes, and so they actually tell us how they're doing. And these are some that you would recognize, the KOOS scale, IKDC, and I know for our audience they're going, what's that mean? Well, basically we ask, these are internationally recognized scales, and they have questions such as, can you walk up and down stairs without pain? Can you squat? Can you get out of a chair? And then the KOOS actually has sporting activities on sports and recreation. If you look at our overall results, and it's not just me, it's my colleagues, the good and excellent are about 80%. So we'd love to have 100%, but it's not. The reality is 80%. And then what that means is they can basically do all activities of daily living with acceptable comfort. And then those in the excellent category are those that are able to return to their sporting activities. This young individual has returned to all of her activities without pain or effusion.
Can people 50 and older still hope that this sort of procedure might be a benefit to them?
Well, you never say never. The bulk of everyone's practice who does this are people under the age of 50. One of my friends, Tom Midas, published on patients, his older patient population, and I believe even his, when he was saying older, it's 40 years up to, I think maybe in the early 60s was his youngest patient. You know, that's sort of the bad news. The good news is that we don't treat people based on their age, we treat them based on their knee. Unfortunately, when you get into your 50s and 60s, there's enough damage that this doesn't make any sense. Plus, you have to look at the risk-reward ratio. My personal history, I have a right total knee, and 6 weeks ago I just had a left partial knee. You know, could I find one of my friends in the world to do this cell therapy on me? I probably could. I could convince them. But it would be a year out of my life trying to recover, and my probability of having a good result may be as low as 60 to 70%, where I was back to work in a week after a partial, and it's going to serve me well for many years. So the risk-reward ratio for people, when they can do well with metal and plastic, many times say, let's go towards the metal and plastic. You know, for the younger individual, if somebody's under 40, we try to do everything possible before metal and plastics even considered. I mean, I will try one procedure. If that doesn't work, I'll try a revision procedure. Between 40 and 50, I have a long discussion with the patient. Depends upon what their goals are. If they just like to walk, maybe some light hiking. If they're a good skier and they just want to do greens and blues, I think metal and plastic. If they want to, you know, be more aggressive, then we'll have to talk about, you know, some other options. But yes, from a realistic standpoint, it's rare to do this in people over the age of 50.